Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Dr. Luis Carracho graduated from the University of Lisbon, Faculty of Dental Medicine, where he obtained his degree in dental surgery in 2013. He joined the graduate prosthodontics program at the University of Michigan in the summer of 2016, where he obtained the combined certificate and master's degree in 2019. After graduation, Dr. Carracho returned to Portugal and has restarted his private practice activity in Lisbon in focus in the area of prosthodontics. His main scientific interests include implant prosthodontics, guided surgery, hard and soft tissue regeneration, and dental ceramics. He's a member of many dental organizations, including the International Team of Implantology and the International Association for Dental Research. Dr. Luis Carracho, I want to say thank you so much. Thank you so much for agreeing to participate in this lecture series. And I want to shout out to your sister, who is my classmate, Dr. Anna Carracho. Very brilliant student. Anyway, take it away, Dr. Carracho, go ahead.
Okay, let me just share my screen. Okay, let me know if it's working, Ugo.
Yes, it is. I can see it clearly. Yeah.
You can see it?
Yes.
Okay, so before I start, let me tell you, thank you for organizing these webinars. It's really a good opportunity to be here. I see that here in the audience we have a lot of familiar faces from Michigan. I can see Dr. Cortez. I can see that we had Diogo here too. And it's really an honor to be here and share my presentation with you guys. I also noticed that most of our attendance is dental students. So let me tell you something. If it's necessary to stop the presentation and make some questions, go ahead. I want this to be a really informal presentation. So go ahead and just do it, okay? All right, so let's start here. Let me know, is it working, Uvo?
You're good.
It's good? Okay.
Yeah.
So, as I said, Dr. Uvo asked me today to talk to you guys a little bit about implant fixed versus removable rehabilitation of the Edentulous maxilla. This is a really interesting topic. I think nowadays is still really controversial. Because everyone is doing full arch cases. We have digital technologies these days that they allow us to do this kind of work in an easier way. But I still think that it's important for us to know when is it necessary to correctly diagnose and see if our patient is a good candidate for a fixed or a removable type of prosthesis. And my goals for today is to let you guys know exactly what are the surgical and prosthetic considerations that we should take into account before we make these decisions. Okay. However, independently of the type of prosthesis that we select for our patients, we all know, even if we are doing complete dentures, that the goals for our oral rehabilitation should stay the same. We want to restore the masticatory function that is related with the chewing ability of our patients, the aesthetics, that it's related not only with the smile, but in edentulous patients, we have to take into account the soft tissue support that it's lost due to the bone loss. It's also important to take notice to the speech that sometimes It's compromised due to modifications on the palatal contour. And by the end of the day, we want to improve our patient's self-confidence. So as we all know, and all the students here in the audience probably know this from complete dentures, we want to give something for our patients that has good retention, good stability, and also a good support. But how do we do this if we don't have the knowledge and if we don't know about prosthodontists? In my opinion, it's impossible, because we need to be trained to understand what happens and to do a correct diagnosis. And after we do this, we can really understand what are the different treatment options that we have for these patients. Some patients, they have complete dentures and they are perfectly fine. Some people, they have 3-4 dentures fabricated every year and they're never happy. So we have to learn a little bit about our patient and who are we dealing with. This will help us to make a good decision and select the appropriate treatment for the patient. We also need to know a little bit about some basic science. We all know these classic studies from Cowwood and Howell, where they evaluated the resorptive patterns on the maxilla. They showed us that when we lose our teeth, our bone starts changing. And this happens not only in the vertical perspective, or it means that we have a vertical bone loss, but also horizontally. As you can see here on this picture, what's happening is that the bone starts shrinking from the outside part of the maxilla to the inside part of the maxilla. And of course, this is different from patient to patient. We all see patients as prosthodontists that are sitting in our chair. They remove the complete dentures and they are blessed. They have a lot of bone. They are perfect candidates for implants. And we have the opposite situation. We have people that remove their dentures and we take a look and there's no bone. We have an atrophic maxilla. So it's important for us to understand what happens to the bone when we lose our teeth. I think it's also interesting to take a look at the statistics. Here we have an interesting study that was done in the United States, and they actually evaluated what was the frequency of edentulous. And as you can see, we have about 45% of edentulous patients on the maxilla, and in the mandible, we have about half of that value. What's interesting is that when we cross-section these two groups with the total edentulous patients, we actually see that almost every patient that is edentulous on the mandible, it's also edentulous on the maxilla. However, the opposite happens for the patients that are edentulous in the maxilla. If they don't have teeth in their maxilla, they probably have a dentate mandible, they have a residual dentition, or they are already restored with implants. And if we think a little bit about it, it kind of makes sense. Because when Brandmark introduced the implants in our field, the idea was to help patients struggling with complete dentures. And we all know that every patient complains 2 or 3 times more to their dentists about the lower denture than the upper denture, because in the upper arch we have the palates that will help us to have a better retention and support area for the dentures. We all have seen these cases, especially those of us that were trained in the United States, patients that were restored with fixed high water bridges on their lower arch and that have a complete denture on the upper arch. And these are titanium implants that are integrated for more than 60 years. And these patients are doing perfectly fine. In terms of diagnosis, this is something that for me it's really interesting to analyze, because when we think about edentulous patients, if we take a look at these pictures, we all see an edentulous arch, right? But we may think that it's the same. We're going to treat the guys that are on the top or on the bottom the same way because they are edentulous, right? They want teeth, they want implants. However, it's not exactly like that. We as dentists should start getting some forgotten sources of information, like, for example, old photos, because in the past, these people, they had teeth, and we want to know, what are we doing? Are we reconstructing the patient in an identical situation? I'm telling this in terms of occlusal plane, in terms of occlusal vertical dimension. Old photos are really, really helpful, especially for those of us that are working with complete dentures, because when we are doing our tooth setup, the first thing that we have to do is to mount the central incisors. And if we have photos, it's already a big help, because we can see if we are dealing with someone with a high smile line, with a low smile line. It's just really helpful. Another topic that should be touched, it's the residual teeth. Nowadays, I see a lot of clinicians presenting and showing cases where people have some teeth that need to be removed. And the first thing they do, it's doing the extractions and convert the patients. In my opinion, that shouldn't be exactly like that, because these residual teeth are very, very good reference points. What I would suggest is to take some alginates or do some scanning and mount the cast in the articulator, because if we already have the teeth in the position, it would make our life much, much easier as prosthodontists to correct the setup for this patient. Another good question that we always forget to ask patients that are edentulous: how did the patient lose their teeth? Because we assume they are already edentulous, let's just focus on the solution and we don't really think about what happened. We may be dealing with someone that suffered from periodontitis, so we know that this patient will have probably an increased risk in terms of peri-implant disease. Or maybe we are dealing with someone that suffers from parafunction and increased load. So if we know this from the beginning, it may not be a good idea to use a metal acrylic restoration for this type of patient. There is also a nice tool that I used to work with when I was in the residency. That's an analog scale to ask the patients how satisfied are they with their currently maxillary situation. This is from a study from Dr. Zitzman from Switzerland, and they basically ask the patients how they feel about comfort, function, aesthetics, taste, speech, and self-esteem. And I'm gonna tell you, this is a really, really nice tool, and it's really, really easy to use. Because sometimes if you see that the patient has been using dentures for a while and they just want a little bit more comfort, they want more retention, we can just add 3 or 4 implants, do a bar, and you can do an overdenture that will make this patient really, really happy. On the other hand, if you see that you're dealing with someone that is really unhappy with aesthetics, that presents with a poor self-esteem, or cannot speak because the complete denture doesn't fit his demands, then you probably are dealing with someone that needs more extensive treatment, and it will be a probably candidate for a fixed restoration. Here, I just added this slide to this presentation because I know we have a lot of students here, and probably some of them are not familiarized with this type of restoration. So here on the right side, we have an implant removable overdenture, which is a prosthesis that has some snaps. They are represented by those blue plastics that you can see on the intaglio surface of the denture, and they fit on a bar on the lower part of the picture that you can see that it's milled in titanium, and it has some small attachments that are called locator attachments. This type of prosthesis, I'm going to tell you, the retention that this offers to patients, it's amazing. So it's similar in terms of comfort to what we see in an implant fixed restoration. Here in the middle, we have what we usually call an hybrid prosthesis, which is usually or traditionally a metal acrylic restoration that has two components, has teeth, the white part, and the gum tissues. And we also have an implant fixed dental prosthesis that it's like the classic crown and bridge work, but in this case, it's held in place by the implants. Another interesting study from Zitzman, she's a really nice author that I like to cite. It's an article where they compared a group of 20 patients and did a preference trial. They split these patients in two groups, one that was restored with screw-retained implant-fixed prosthesis. As you can see on the picture here on the right, you have the teeth that are emerging directly from the gum, and another group that was restored with a removable overdenture that it's on the right. You see that underneath this denture, there is a small bar where the denture clicks and stays in place. The interesting thing about this study was that they found out that there were similar outcomes in terms of comfort, retention, function, taste, and also speech. But what really amazed me was that they found out there was a greater improvement in terms of aesthetics for the patients that were restored with an overdenture. And for us, that may be something that we wouldn't be expecting because it's a removable prosthesis. It wouldn't look as good as a fixed, right? But we are dealing with edentulous patients, and that's what we have to think about. Sometimes the soft tissue support, it's really, really important. And if you have a patient that has a collapsed lip or that is suffering from loss in terms of volume, the overdenture may be the best option. Another interesting study, it's a similar study that was published on the Journal of Dental Research, actually used 13 patients. This was a little bit more sophisticated. They placed 4 to 6 implants on the maxilla, and they restored all the patients first with an implant fixed prosthesis. They used this prosthesis for about 2 months, as you guys can see here on the pictures on the right side. And after that period, they removed these prostheses and they converted the patients for removable overdentures, as you guys can see on the picture here. This is the small bar that I was talking about, where the denture used to snap. And again, one of the 4 main reasons for the patients to select an overdenture over a fixed prosthesis was aesthetics. And I really want to emphasize this because these patients also reported a better cleansability and speech. And this is really important because when we are dealing with edentulous patients, we have to think about this. Almost all of these patients are going to be in 3, 4, 5 years dealing with a situation where it's going to be hard for them to clean a fixed prosthesis because they are elderly patients. So sometimes we have, even if we plan for fixed restorations, we have to plan in the future, and is not a downside of doing this, to convert these patients for an overdenture, because that's the only way the implants are going to stay integrated and we're going to have access for the patients to clean. So let's go for the diagnosis. As a prosthodontist, I learned in my residency that the first thing I want to do if I want to start working on implant case and the patient has a complete denture is to look at him from a profile. And then the first thing I ask him to do is to remove the denture. If I see something like this, as you can see the picture in the middle, the patient is wearing the denture, and when it removes the denture, there is a collapse on the soft tissue. I already know from the beginning that this patient is going to be for sure a candidate for an overdenture. This is not something that should be restored with an implant fixed or hybrid type of prosthesis, unless the patient wants to have a lot of bone grafts done, a lot of hip grafts, and some extensive surgery that, in my experience, most of these patients want to avoid. An easier way for you guys to do this, if you are not sure about what type of prosthesis you want to do, you can do what I call a trial denture. In this case, we had a patient that had a whole partial denture that was fitting in a couple of surveyed crowns, and she wanted to be converted for a fixed restoration. So we did a manual wax up. We converted this wax up into a suck down, which is a kind of a plastic that it's used to retain provisional restorations. And we just applied a couple of composite or acrylic inside and put this in the patient's mouth. And here, as you can see on the bottom pictures, these teeth are emerging almost on the top of the ridge. It means that this patient probably is a perfect candidate for one of those implant fixed restorations that emerge exactly as natural teeth. The next step is to take a look at the intermaxillary relation. So if you guys look at these two pictures here, we can see that on the left side, the teeth are positioned exactly on the ridge and exactly aligned with the implants. However, on the right side, we see that the teeth are positioned way far from the ridge, and we have a horizontal discrepancy from the implant head to the prosthetic restoration. This means that this type of patient should be restored with something that has a flange to compensate this deficiency. And the only way to do this, again, is with a removable overdenture. At least a correct way. The third step is for us to take a look at vertical dimension. Here, we all know that we have a lot of different ways of assessing vertical dimension. We can use facial proportions, like the Thompson method. We can use phonetic tests like Silverman. We can use facial marks like Niswonger or the Willis method. So my advice as a prosthodontist for you is to use 2 or 3 different methods and see if you are in that range. If you are in that range and if they are really close in terms of numbers, you're probably doing it the right way. Sometimes we also need to take a look at the occlusal plane on the opposing arch, right? Because we all have these situations in our practice where patients came to us and they ask us, doctor, I want to have some implants placed. But if you are not paying attention, and if you're not taking your pictures, if you're not mounting your casts, you may be committing a big mistake, because sometimes the best thing to do is to correct the opposing arch, change the occlusal plane, and make everything work in the exactly position that you want for your upper restoration, so you have enough space in terms of prosthetic space, but also fix this kind of roller coaster situations. Otherwise, you're gonna be probably dealing with a lot of trouble in your future. The next step would be to evaluate the lip line and the smile line. Here, we all know that if the patient has a low smile line, probably is just showing less than 70% of his central incisors. If the patient has an average smile line, he usually shows the whole central incisor. Sometimes we can see a little bit of the papillas. And the patient with a high smile line, usually I always laugh in the congresses when people say that they are the critical cases, they are really difficult to treat, but because they are really risky. But if you really stop a little bit and think about it, the risk per se, it's the same. The only difference is that if you would make any mistake, you would be exposed. So in terms of treatment, it's the same thing. The other thing that usually no one talks about, it's the upper lip length. Here, the important thing for you guys to retain is that if you see that your patient has a really short lip, what's going to happen is when this patient smiles, he's going to show a lot of his teeth and gums. So if you have an edentulous patient and you see that he has a short lip, when you're mounting your teeth and doing your setup, you're probably going to end up with a situation where the whole teeth is going to be showing, and also a little bit of your wax up. Okay, the position of the central incisors. This is, for me, the most critical part, as I already said in the beginning, because this is the beginning of everything. It's like complete dentures. If you don't know how to set teeth and to correctly position the central incisors, you can place your implants, you can have a beautiful restoration, but by the end of the day, it's not going to look good, and the patient is going to complain about the speech, about the function, and you're probably going to have to send him to a prosthodontist or to someone that knows how to do a correct setup. Here, the position of the incisors are limited by multiple factors. The display arrest, as they taught us in complete denture, we ask the patient to stay with the lip at rest, and then we position the teeth, usually with 2 or 3 millimeters of the borders of the incisors showing. The occlusal plane, of course, that limits, it's a vertical limit for the positioning, and these all should be tested by the end of the day using phonetic tests. I learned to use the phonetic tests, the S sound and the F sound, because they really give us an idea of the assessment in terms of position and comfort for the future prosthesis that we are planning for the patient. As you can see, it may seem easy to do this and to position the teeth, but in this picture you can see all the horizontal and vertical factors that will influence the position of the central incisors. And then, as you guys can see, there are a lot of factors that play a role in this situation. Okay, another important thing, the transition line. Why is this important? Probably most of you guys don't know what is the transition line. The transition line is a line that determines the transition between our future prosthesis and the patient natural soft tissue. Take a look at this picture. Here, if I'm just going to do the extractions for this patient, place implants, and then do a restoration, my prosthesis transition line, it would be the red line. And this means that the transition between the prosthesis and the soft tissue would be showing. However, if we are planning for a hybrid type of prosthesis, we need to put this line 3 to 5 millimeters above the smile line, because we don't want this to be shown. And I'm going to show you why. This is the problem. When we don't do bone reduction and we don't properly plan our cases, this is what happens. We have these aesthetic problems that result by applying hybrid prosthesis on the top of the ridge without performing the correct treatment and diagnosis. This patient, of course, is unhappy. She paid a lot of money for this restoration. She already has the implants installed, and by the end of the day, when she smiles, everyone can see that this is an artificial prosthesis because the treatment plan was not correctly done. This is the other problem that I see frequently in my practice, flanges in fixed prosthesis. And I want to tell you, for me, this is the public enemy #1 in prosthodontics. You see this happening for 2 main reasons. One, it's because the treatment was not correctly planned and bone reduction was not performed. And you have situations, as I showed you before, where this happens and the dentist and the technician want to hide this. So they had a lot of acrylic or porcelain on the buccal part around the ridge and create a flange. What happens is that the patient has no access to do the cleanings. The patient cannot floss. The patient cannot use a water pick to clean this line. And we end up with situations that usually starts as a mucositis and evolve to what we call a peri-implantitis. So in a period of 3-4 years, the patient that invested a lot of time and a lot of effort in having implants done, prosthesis that would probably, the idea would be to give him back his function and his aesthetics, would be lost. So that's one of the reasons. The other main reason for this to happen is, again, misdiagnosis. These patients, if they don't want to have the bone reduction done, and if they don't want to have this kind of prosthesis, the dentist has to tell him, look, you can have an overdenture that would work. It would be a restoration that would be removable. It has a really good retention, good aesthetics. The only difference is that you can remove it and you can clean underneath that flange. That's exactly what we did in this case. We had a patient that was referred to us in the prosthodontics clinic. The implants were already placed. His dentist told him that he would have a fixed prosthesis, but after I did my setup, I took a measurement and I saw that we have about 12 to 15 millimeters of horizontal discrepancy on the alveolar ridge, and that this patient from the profile would benefit from a flange. So I told him, look, we're going to do something for you that it's as good as a fixed restoration, but you can do maintenance. You can remove it and you can clean it. And of course, we gave him this restoration. I planned the case from the beginning and everything went as planned. This is another problem, the prosthetic space. As you guys can see here from this picture, when we have a natural tooth, we have a periodontium that is perfectly healthy. We have a lot of bone. We have a teeth emerging with a natural emergence profile from the gum. And these situations don't really happen a lot when we are working with implants. This happens when we have someone that was recently edentulous, so the ridge didn't really resorb, so we can plan an implant fixed dental prosthesis, as you can see here on the middle, that requires about 10 millimeters of space. We know that the central incisor in average measures about 11 millimeters, so in terms of prosthetic materials, to restore a case like this, we would need space for abutments and for our framework and veneering. So it would be a minimum of 10 millimeters. If we want to plan for an hybrid type of prosthesis, of course, we're going to request more space because this type of prosthesis needs more components. We need to use multi-unit abutments. We use a milled bar, and on the top of that bar, we're going to apply the acrylic wraparound and also the prosthetic teeth. So if you don't have this space, your hybrid prosthesis won't be successful and you won't have enough space to fit all the components. For the overdenture, of course, we still need more space because we have more components. We need at least 16 millimeters of space. And we have space for a bar, we need space for locators, we need space for housings, and also for a mesostructure that will fit the denture and snap it on the bar. So if you don't have 16 millimeters, you better do some bone reduction, or you better talk with your patient because this won't be the appropriate restoration for him. And why is this important? Here you can see a case that was restored with a hybrid type of prosthesis, a metal acrylic prosthesis, and the patient kept coming for our clinic for like every 3 or 4 days with a fracture. And this happened because the dentist that did this restoration didn't know better. He didn't know that he needed about 15 millimeters of space to do a metal acrylic restoration. And this happens because you need bulk for the acrylic. If you don't have space and you don't have enough volume for your acrylic and for your denture teeth, just use a different type of prosthesis, use a zirconium prosthesis or an implant fixed prosthesis, a metal ceramic, because otherwise this is what's going to happen. And how do we determine this space? If we still live in the analog world, we can do our walks up like we do exactly for our complete dentures. And after that, we grab some silicone and we put it on the model and we do a silicone index. With this silicone index, you can actually take a look, as you can see here on the bottom pictures, and measure this distance from the alveolar ridge to the incisal plane. And then you can actually be accurate and say, okay, I have 16 millimeters, I have 15 millimeters, I have space for this type of prosthesis. So I'm not going to be having a lot of technical problems and mechanical problems in the future. Nowadays, we can do the same thing in the digital world. We have CAD softwares that we use to design our bars and restorations, and we have implant planning softwares. And this makes our life much, much easier if we know how to take advantage using these technologies, because we can minimize the errors and we can make our measurements even before the implants are placed. Okay, so here we have a clinical case that I did. I think it was my first guided case that I did in Michigan. It was a patient that came to the clinic complaining about his upper bridge. He had a metal ceramic bridge that was fractured and loose, and he wanted to have some fixed teeth. He wanted to have something that give him comfort and that he can chew with. This is the panorex of the patient. Here you can see that this is a periodontally compromised patient. Of course, we see that there is a lot of bone resorption. We have a lot of attachment loss, and these metal ceramic bridges were really mobile. Here are some clinical pictures. We can see that the patient presented with a lot of ceramic fractures. The oral hygiene, of course, it was a big problem for him, and he wanted us to do something for him. So you can see here also an occlusal perspective of the same case. Usually this happens a lot when the patients have splitted bridges. You can see there is some small gaps between the canines and the premolars. So this work probably was in his mouth for a long time. So what are our treatment options? How do we select the treatment option for this patient? If we are an oral surgeon or a periodontist, probably you're going to tell him that he needs 6 implants. He doesn't have enough bone height on the posterior aspect to have standard sized implants, so you need to have sinus floor augmentation done. If you are a periodontist, probably you want to place more implants. You probably want to place 8 implants, do extensive sinus surgery, and give him splitted bridges as a treatment option. Or you can also do this. You can still place the same 6 implants, but avoid the sinuses. You can use short implants in the posterior area, or you can still use the same 6 implants, but tilt the posterior aspect of the distal and more mesial implant. Or you can do less implants. You can do 5 implants and assume that you're going to have a cantilever on your prosthesis. Or even if you work in certain clinics where the only thing they know what to do is this, you can always go to the recipe and apply it. So what we did for him, we did the extractions. We gave him an immediate denture, and we start giving him some oral hygiene instructors to see if he improved the hygiene, at least using the complete denture. After a couple of months, he came back. He was ready to plan the implant surgery, And the first thing we do when we do this kind of cases is to do a dual scan technique. So the patient come to us, we reline the denture, and then we put some markers on the denture and do a CT scan. These marks will help us to superimpose the patient's denture with the CT scan and allow us to take a look at the bone and the prosthesis that is in place. The second most important thing that we have to do is ask him to remove the denture and give us a big, big smile. When he does this, we take a picture, as you can see here on the right. In this picture, because we are planning an hybrid type of prosthesis, as you guys know, we need at least 15 millimeters of space, and we don't want the transition line to be showing. So as you can see, there is some gum showing when the patient smiles. So this means that we're going to do some bone reduction, because this line needs to be pushed up about 3 to 5 millimeters. Here is the CT scan of the patient. This is the complete denture. And then we did our measurements. We measured from the incisal edge to the alveolar ridge, and we saw, oops, I only have about 10 millimeters. So I don't have enough space to fabricate a hybrid type of prosthesis. So this means that I'm going to need more space, and I'm going to need to plan my implants a little bit deeper. So we can make sure that we're going to do some bone reduction. And as you guys can see here in the picture, we can be as precise as exactly measuring how many millimeters do we need to reduce from the implant head to the alveolar ridge and transition this to our surgery. So from the beginning, we are already avoiding problems for our future prosthesis, already in the surgical phase. Here you guys can see the implants were planned, and they are all emerging in a more palatal position. This is mandatory if you're planning for fixed restorations, because in my opinion, nowadays, all the fixed restorations should be screw retained. There are plenty of literature showing us there is a big problem with resin cements, especially when we are cementing on dental implants, because we don't want to have what we call cementitis. That is like peri-implantitis caused by residual cement. Here are some pictures of the surgery. We started by positioning our guides in place, then we remove the guide and start opening a flap. We can measure with the periodontal probe how much millimeters do we need to remove in this anterior area, and then we do our bone reduction using the rangiers and the bone burrs. Then we just apply some securing sutures to this flap and reposition the guide. This guide, as you guys can see here, is positioned using 4 guide pins. That means that this guide is really, really stable in the patient's mouth and it's not going to move. And another advantage of using guided surgery on the upper arch, even in cases like this where you have to do bone reduction, is that you have the palate. So when you're stabilizing the guide, you want to make sure that you're pushing on the palate and the guide is really, really fitting and it's not rocking. So after the guide is secured, we start our drilling protocols. Here you have some pictures that were taken when we were placing the implants. You can use your handpiece, you can use other devices to place the implants, and by the end of the day, this is what we have. We have a patient where we plan to do this from the beginning, and we achieved this that we have on the right. So this is not something new. On the Republic book from Plato, they already stated that the beginning is the most important part of the work. So I hear this a lot. If you fail to plan, you're gonna fail your cases. It's 100% sure. Here are some pictures on the beginning, the patient with the old metal ceramic restorations and the final hybrid restorations. Here I just put this picture because access to cleaning is really important. Here you can see on the anterior bridge where you see the arrows, there are some small holes in this area. This is for the patient to use his super floss and to use some small brushes and actually clean between the denture and the soft tissues, making sure that we don't have any bacteria or any food remnants on the prosthesis and on the implants. These pictures are also from the final rehabilitation. You can see here that we did a good tooth setup for the patient. In the second picture, you can see that the border of the incisal, the central incisors is correctly positioned. Here you can see also on the bottom the smile dynamics. And I think if you do a good work and if you know how to plan complete dentures, it's really, really easy for you to transition this into implant restorations. That's a key point that I learned in my program and with the people that were teaching there. And I tend to believe that it's really true because most prosthodontists do really, really good work in terms of planning. This is another important slide. You can see this fixed restoration. It's not concave, it's a convex or flat restoration. And this is important. If you guys remember that slide where I showed you a patient with flanges, if you have a concave prosthesis, this tends to accumulate food and bacteria, so the patient won't be able to clean. If the intaglio surface it's concave, convex or flat, it would be much easier for him to use a water pick or just clean the denture and make sure that the implants are going to stay there for a long time. So after all this information, what determines your treatment approach? Are you going to place the implants first and then think about your prosthetics and do a surgically guided approach? Or you're going to think a little bit more and position your teeth in the right position and then think about the surgical aspects? I think this slide is really important, especially for people that are working in a multidisciplinary environment, because a lot of times what we see, especially in clinics that have like 7 or 8 doctors working at the same time, is that guy did the surgery, removed the teeth, he placed the implants, then you send the patient to the restorative dentist or to the prosthodontist and expect him to place fixed teeth or an overdenture without having any knowledge about all this planning. So, of course, we all should work prosthetically guided. It's really, really important, and I really want to reinforce this idea. Even if you're working with the periodontists, probably they're going to be mad at you at the beginning if they are not working like this, but even if you're doing guided bone regeneration, you need to position your teeth in the beginning, because the surgeon needs to know how much tissue volume it's needed in terms of augmentation. He also needs to know if it's predictable to do it, how many surgeries are going to be necessary. Are we talking about vertical or horizontal augmentation? All these questions can be answered if before the surgery we do our setup as we do for complete dentures, or we do our walks-up and scan the patients and with the CBCT. Otherwise, we are just doing surgery and expecting the teeth to appear in the right position. This is important because when patients come to us, they are not asking for implants. They are asking for teeth. So it's an important decision for us as practitioners to do this if we want to satisfy our patients and if we want to do good work in our practice. And the same thing applies for the guided bone reduction. If you have someone that is planned for an hybrid type of prosthesis, we want to ask some questions too. We want to ask if the difference is that probably we want to see how much bone do we need to reduce, because the prosthetic components, as we've seen before, need space. If we don't take this bone, take a look at this. If our correct position for the teeth is this one, and we don't take this bone, and we are planning for this type of restoration, we don't have enough space, right? The implants are going to be placed at the ridge, and then that's it. You don't have space for the rest of the components. You don't have space for the multi-unit abutments. You don't have space for your titanium or zirconium bar. You don't have space for the pink acrylic and the pink ceramics. And then actually working prosthetically guided. It's also interesting to notice if sometimes we need to apply this type of restorations over dentures. Take a look at the difference between these two slides. In this one, we have a small hole between the upper part of the lip and the ridge, right? When we have an overdenture, this hole is filled with acrylic that is compensating and is supporting this upper part of the lip and the soft tissues. So these type of restorations, the overdenture type of restorations, are the ones that are going to be indicated for your patients with atrophic ridges. It doesn't matter if you want to put zygomatic implants, if you want to use pterygoid implants, you can do whatever you want. The only way to recover aesthetics and to recover the lip and soft tissue support and still allow the patient to have access for cleaning is to give him an overdenture. So what are the treatment options that we have for the edentulous maxilla? We have a different number of implants. We can distribute the implants, as you see, in a different way. You can use tilted implants. We all know today that tilted implants have the same success rate as axially placed implants. We can use cantilevers. We can use sinus floor elevations and place zygomatic implants. In terms of surgery, we have a lot of options. But before we think about all these situations, we have to think about the teeth and where they should be positioned. In my opinion, the number, the size, and the distribution of the implant fixtures should be based on the final prosthodontics plan and also on the clinical conditions. And we all know there are prosthodontic principles that will really tell us who gets what and why. And these are basic principles that come from complete dentures. They are the retention, the stability, and the support. And that's what we need to focus when we're dealing with these patients. Here is a small example that I took from a class from Dr. Razug. He's a really, really experienced clinician. And I wrote this here because it really made me think. He was telling us, if you're dealing with someone that over a period of 5 to 10 years had one denture or a couple of dentures fabricated, and this patient came to you and asked you to have dental implants, probably you're looking at someone that would be happy with a lower overdenture with 2 implants and the upper overdenture with a bar. However, if you're looking at the same patient that over a period of 5 years have been using 6 to 7 sets of dentures, this person probably won't be a good candidate for an overdenture. So you may start planning your surgeries, you may start planning your bone reductions, your tissue and bone augmentations, because this patient will be happy with a fixed type of prosthesis. This is for you to understand that not everyone needs to have the full extensive treatment. Some people are perfectly fine with an overdenture. Here we have a small summary of our treatment options. We all know from the literature that we should not place only 2 implants on the maxilla to stabilize complete dentures. This is totally wrong because these implants will work as an engine axis and they won't actually help anything. So my advice for you is, if you see someone doing this, tell them to place the implants first and then fabricate the denture, because if you fabricate the denture first and then place the implants, the patient won't notice any improvement. And sometimes you may even start complaining because you lose the vacuum effect of the complete denture. The other option is to place 4 implants and use a bar to retain this overdenture. It's a situation that can be done either with the bar or only using single attachments. I may tell you that in terms of patient expectation, this type of treatment, in terms of comfort, it's similar to a fixed prosthesis. In terms of soft tissue support, if the patient has atrophic ridges, this is the best type of restoration. You still need to cover the palate a little bit, but it's not a full palatal coverage. Also, in terms of implant positions, nowadays we have CAD/CAM systems that can compensate the positioning of the implants that are not really detrimental for these type of cases, because the bar is going to be retained on the implants and then the prosthesis will snap on the top of it, so we won't have any aesthetic complications. And in terms of finances, of course, it's a situation that it's less expensive than having a fixed solution. The fixed solution, we can use between 4 to 8 implants for the maxilla. We can use hybrid type of prosthesis, as you guys saw, where we have the white component of the teeth and the ceramic component on the gingiva, or we can do a crown and bridge type of work on the top of our implants. Of course, that in terms of patient's expectation, I would tell you that if you have someone that has a terminal dentition and never used the complete denture, this probably is the treatment of choice for them. Also, don't select this type of implant treatment for patients that have atrophic maxillas, because you won't be able to compensate for the soft tissue support, and you will end up creating a problem using flanges, or probably applying a restoration that has a transition line that is going to be shown. In terms of implant position, if you plan for implant fixed restorations, make sure that you do your tooth setup, because this needs to be prosthetically driven. Nowadays, we can compensate about up to 30 degrees of angulation if the implant is not correctly positioned. But to be successful with this type of prosthesis, you should do a prosthetically driven approach, and ideally you should use guided surgery. So should we do fixed restorations at any cost? Here is an interesting study from Rosen and Gainter that was published on the Journal of Oral and Maxillofacial Surgery, where they followed a group of 33 patients that were restored with extremely tilted implants in the Edentulous maxilla. So if you guys take a look at this panorex, these are patients that had an atrophic maxilla. The implants were placed on the nasal bone, they were placed through the sinus, and then they received fixed restorations to be restored. And what we can see from the table on clinical complications is that 36.8% of the patients were complaining of aesthetic problems, 42.1% of the patients were complaining about speaking problems. And if you take a look at this picture, you can see that cleansability, it's impossible in situations like this. And the phonation, the articulation of the tongue with the prosthesis, it's gonna be very, very complicated because you see implants emerging way far palatal to the prosthesis, and they are occupying a space that should be restored in a different way. This is a tool that I use a lot these days. It's from the ITI organization. It's called the SEC tool. It's a surgical and prosthetic risk evaluation that will help you if you are inexperienced working with these cases, or if you just want to try something to give you a better guideline in terms of planning the surgery and the restorative. You can use to determine if your patient will be fixed or removable type of prosthesis. In conclusions, I want to tell you that in my opinion, it's our obligation to provide the patients with the correct diagnosis from the beginning and an adequate recommendation for either a fixed or removable type of prosthesis, because we are the clinicians. We have the knowledge, and we should guide the patient for the decision that is best for him. It doesn't mean that we don't explain that fixed or removable can be done. It's guiding the patient to what it's the best long-term success for him. There are, of course, clear indications for this type of prosthesis. We should evaluate the position of the crowns related to the bone crest. We should evaluate the presence and the amount of bone deficiencies, and it's mandatory, always mandatory in edentulous patients, to evaluate the lip support. Don't forget, if you're treating these patients, ask them to remove the dentures, take a look from the profile. It's really, really a simple thing that you can do, and you can start your case and plan it much easier. Of course, we have to take the patient's desire into account, but we need to make sure that our final restorations are aesthetic, but also cleansable, because this cleansability, it's important not only for us, but also for the patient. Because if we do everything right and the patient goes home and he has no access for cleaning, you guys can be 100% sure that he's gonna come back to your office in a couple of years, and you're gonna have to restart working everything again. We all know that when we plan implant fixed dental prosthesis, we only have limited compensation for the implant position. We all know that we should use provisional restorations to do the gingival conditioning. And when we select this type of prosthesis, we know that it's more technique sensitive and, of course, more expensive when we compare it with the removable overdentures. The overdentures, if they are correctly planned and if we have enough space for all the components, they should not be seen as a fallback or a second choice or even a disappointment for the patient because they are removable. They should be seen as a really, really good restoration, and they should be planned to fit the patient needs, not the other way around. We should not gather or start doing surgical procedures that won't fit our patient needs. So to end, thank you all for your attention, and keep in mind when you're treating these patients that one size does not fit all. So we all have to adapt our treatments and make sure that we are offering the best treatment for that person. Okay? Okay, thank you.
All right, thank you so much, Dr. Carracho. That has been very, very, very full and step by step. I think if you go, in fact, as you were speaking, I just told myself I need to go back to these lectures and develop a little index, something that you can use for every patient in terms of if you have it. It's called treatment planning. Without, I know we want to jump into doing some big stuff, but if you go step by step, you will even know whether or not you should be placing implants or not. Sometimes
I'm losing you.
Yeah, go ahead. I'm like, treatment planning is really key, and I can see a slide from there that I can, go back to. Anyway, I just want to thank you so much for that.
Okay, man. Thank you very much for the opportunity.
The other question here, it said, what is the aim of bone reduction, in relation to the smile line?
Okay, so in relation to the smile line, can I go back to the presentation? I think
Go ahead.
I think we have a good picture to show that. Okay, let me just find it. That's a really, really good question. And I know that for someone that never heard about this may be a lot of information, but the goal of bone reduction, when you have a high smile line, look at this case. This patient, she was told that she would have a hybrid prosthesis. You all know that the hybrid prosthesis, it's a restoration where we have gum tissue and acrylic teeth. It's a metal acrylic type of restoration. So when you fabricate this type of prosthesis, you need space for the titanium on the bar, you need space for the acrylic that wraps around the bar, you need space for your multi-unit abutments that fit on the implant, and also you need space for your acrylic teeth. These type of restorations, they are less expensive than the metal ceramic or the zirconium ceramic type of restorations. However, they need more space for all these components. And if you don't do that bone reduction, what happens is that you can still use that type of restoration, but this is what's going to happen. Because the patient has a high smile line, all the transition between the prosthesis and the natural soft tissues is going to be showing. You see here we have like a gap, a transitional gap between the prosthesis and the alveolar ridge. And this gives a really artificial look to the patient when he smiles. And people that pay for this kind of restorations that are sitting in the chair for a long time, having surgery done, implants placed, some hours doing impressions, they expect you to deliver something that is aesthetic and that it's functional. So if you don't do the bone reduction, this is going to happen. If you don't do it and you still want to do the same type of prosthesis, this is another common mistake that we see a lot of dentists doing. You do this, you do a restoration that has a flange on the top of it, and then the flange, of course, it covers the smile line, but then the patient cannot access to clean because the flange of the prosthesis, it's touching on the patient's gum, and it's actually blocking any access to the intaglio surface, you know? So if you don't do the bone reduction and if you don't plan the bone reduction, you can expect to have these situations, or you can expect to have these situations, or you can also expect to have these situations because you don't have enough space for your materials. I don't know if that answers the question, Ugo.
I believe so.
Okay.
I have another question here from Dr. Peter. It says, it's a question related to the clinical case you showed. When you place the implant surgically guided,
yes.
and you do the bone reduction just before, how do you assure you reduce the bone to the right level?
So the way you do it, in this case, nowadays you can use bone reduction guides.
Okay.
But in my opinion, it's more expensive. You have to open a huge flap to sit the guide on the alveolar ridge. And in this case, because we only needed to do bone reduction on the anterior area, what we did is we opened a small flap, and with a periodontal probe, we measured from the alveolar ridge to the amount of bone reduction that we wanted to do. We measured about 5 to 6 millimeters. We did some marks with the burr on the anterior area, and then we followed that with the rangiers and the bone reduction burr.
Okay.
I think I can show you here. It's really...
Go ahead. Yeah.
Am I sharing the screen or no?
Go ahead. You can share your screen now.
Okay. Let's see. Is it working or no?
Not yet.
Not yet. Okay. Let's go here. Share screen. You can tell Dr. Peter he can call me, and I will teach him. Okay. So let me see if I have that slide. It's somewhere around here. I wish I could put more cases in here, but
I'm sure we're going to
lately I didn't have a lot of time because of the elections. So I would be more than happy to give you another session. So here we have the double scan technique. We have the denture scanned in the patient's mouth, and we have the alveolar ridge. You're going to be doing a lot of this in Michigan, Uvo. Dr. Zug is a big fan of this type of treatment. So as I told you, we measured this distance. We saw in our program that we didn't have enough space, so we placed the implants deeper. We knew that we have to do some extra bone reduction to have enough space for all the components. And here, when we place the implants, we are really, really precise. We can measure from the tip of the ridge to the tip of the implant that we planned, and we see that we have to reduce about 5 millimeters. So the way to transition this to the surgery is when we open a flap, it's only on the anterior area. You can take a look at the pictures. We have a computer or a printout of the surgical planning, and we measure this distance. We mark it with the burr, and then we use rangiers and the bone burr until we reach the desired bone reduction.
Okay. Nice.
Okay.
Anyway.
All right.
And there's a question here. I think it has to do with. All right, no problem. I think we are. This has been an interesting session. We do have a session tomorrow with Dr. Gabrielle Jackson from Dallas, Texas. She'll be speaking on immediate load anterior implants. We also have Dr. Bernard Saglik, who will be speaking on digital removable partial denture. These webinars are they've turned out to be very, very rich in terms of content, and some of the videos will be available on YouTube for you to go back to. Dr. Carracho's, I believe, Dr. Carracho, I'm able to put your, should I?
Yeah, go ahead. I'm all about sharing and that kind of stuff. So I already told you, I think that what you're doing here it's really important, because you're collecting experience from people in prosthodontics and implant dentistry. Everyone has a different background, and you're sharing this with students and a broad audience. So I'm really happy to be part of this. So you feel free to share it, okay?
Obrigado.
De nada.
All right. So we're going to put this video, video clip on YouTube, and after which I'm going to send you 6 questions just to test, just comprehension of the concepts. Dr. Carracho has sent us 6 questions with answer options, and I'm going to send that to you later tomorrow. But looking forward to seeing you guys. Thank you so much, Dr. Numbisi, Dr. Carracho, for making our Saturday very, very insightful. Thank you so much, and you guys take care. I'll see you tomorrow.
Okay, bye-bye.
Okay, bye-bye.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA. private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator